crowd. That's why we keep coming back to Boca. I didn't do Pilates yet. No, I've been really a bad girl. I haven't done that. But it's so wonderful to be here. And we come back every year. We're just trying to figure out which weekend in February next year to come down here. So start putting it on your calendar. So I'm going to give everybody a couple more minutes just to file in the room. We've got an amazing program today. Lots of good information, wonderful speakers, good crowd. What's wrong with this side of the room? Are you guys awake over there? Oh yeah, there's motion. I see it. Okay, good. Good, good, good. Okay, so as you know, we're filming. So every year we film one seminar, and this is it. And so if you don't want to be on camera, tough. Because there's really no escaping it. No, seriously, if anybody's really that shy, just sit at a table in the back. But this does not ever strike me as a shy group. All right, so I'm Susie Novus still, president of the IMF, one of the founding members, and it's my pleasure to just give you a little bit of an overview on where we are 23 years later. And I just want to remind you that I work for you. So if you have any ideas, suggestions, it's always welcome. So as many of you know, the IMF has always focused in 4 areas: research, education, support, and advocacy. And just in case you're wondering, which one of those areas does this relate to? Education. Yeah, all of them, exactly. Okay, good, you're awake. Or this lady right here is awake. Now, since we started 23 years ago, when it was just a couple of people, our membership, there really is nothing to join, but people just wanted to call themselves members because they felt like they really belonged to something. There's now roughly over 350,000 members all around the world. We're in 140 countries, and we started with a scientific advisory board of only about 12, and now there's 72 scientific advisors. But I think more importantly is the International Myeloma Working Group, which is an amazing body of the top doctors from all around the world, all the top institutions, and many of them are here today. There are now 165 members, and they really are charting the course of what we're going to do with myeloma research, treatment, and all the advances that are being made. And over the years, we've managed to raise $91 million. Now, does anybody want to make it 92? Do I hear 92? Okay. So this is our growth. We really had a huge growth spurt over the past 10 years. And you can just see that big chart going up on the right-hand side of the page. So it's really good that we're reaching more and more people, but we're still not reaching everyone, and that's our goal. We don't want anybody who has myeloma not to know about the IMF. One of the most exciting things that has happened past couple of years is the launching of the Black Swan Research Initiative, and I'm sure many of you have been hearing about Black Swan. Black Swan. Black Swan is a global collaborative approach to finding a cure for multiple myeloma, using the new drugs in novel ways, determining, this is really key, the right combination for the right patient at the right time. And then we have to measure that response with the most sophisticated tests to ensure that we have indeed reached a cure. So here I am standing on this podium saying to you for the first time, I think we're there, and you're going to hear more about it. So, research, we do a lot of research. As I mentioned, we have 165 members of the working group from 31 countries. They have published the most amazing body of work ever done, 38 peer-reviewed publications, and they've got 11 pending. What does this mean? This means that these doctors get together and write papers on everything about myeloma treatment, diagnosis, the whole enchilada, and then they're submitted to the most prestigious journals. These papers become the guidelines for any doctor anywhere in the world to pick up one of those papers and know how to treat their myeloma patient. It's like if you didn't know how to cook, and all of a sudden one day somebody handed you a cookbook with recipes in it, you'd be like, oh man, this is great. That's what these papers do. They meet annually at ASH, the American Society of Hematology, and they also have an annual summit called the IMWG Summit that meets once a year, and the body of their work is just spectacular. Some of you who were here last night saw little bits of it in the video that I showed. So these are the annual summits, and we've got one coming up in June of this year in Milan. Now, we tagged this summit onto an existing meeting called the European Hematology Association. So that way, the doctors are already there, and we don't have to go to the expense of flying everybody all over the world. Another really important facet of the IMF is the Nurse Leadership Board, and many of you heard Kenna Miller yesterday. She's a member of the Nurse Leadership Board. These nurses work so hard to put together guidelines on how to overcome the many side effects that are associated with these novel therapies so that patients can stay on the treatment long and get the maximum benefit. They do a spectacular job, and we're really proud of them. Seminars, again, we started these in 1993, so I've been doing them for a long time. And just in case you can't get enough, you can come to Georgia in May, Los Angeles in August, or Short Hills in October. And we're celebrating 21 years of organizing and conducting these patient and family seminars. We also have regional community workshops. That was the brainchild of my good friend and colleague, Kelly Cox. He said, you know what? Everybody can't go to these seminars. Why don't we go into smaller markets? So this year, Kelly's going to be going to Portland, Salt Lake City, Albuquerque, Denver, Memphis, heck, I'd go to Memphis, Kansas City, Virginia Beach, Jerry Walton, Chicago, which is not a small market, but anyway, Chicago, Minneapolis, Fort Myers, and Nashville. We have an amazing group of people, our support group team, and there they are, Robin, Nancy, Kelly, Sue, and Ann. And these 5 people do an amazing job of working with over 142 support groups around the country. So let's give these people a big round of applause because they're doing such a spectacular job. If you're thinking about starting a support group in your area, just get with any one of them and they'll be able to help you. So patient support, we do monthly, they conduct monthly conference calls with support group leaders. We have a quarterly Living Well with Myeloma conference call. How many people have participated, dialed into those Living Well with Myeloma calls? Not that many. You really should. You should get on if they're fantastic. Doctors like, sir, what's your name? Oh, that's Dr. Durie over there. Participate in these, and they really cover a broad range of topics. And then every year, we have a support group leaders that go to ASH, and those are key leaders that go to that big meeting and then report back everything from tweeting to blogging, and they represent the patient community at these very important meetings. Every year we have a support group leader summit, which brings these leaders together from all around the country, and then we have people that come in from Canada, and last year we had a representative from Australia, and it's wonderful for support group leaders to get together and really plan their strategies on how they're going to really help their patient communities. Hotline. How many people here are utilizing the hotline? That's it? Oh, come on. You got to be calling the hotline. That's Judy, Paul, and Missy. They're wonderful. They have a wealth of information. The hotline is just incredible. So what are people calling about? This just gives you an idea of all the different types of questions that they're answering on the hotline, and they really stay up to date on everything. So if you have a good idea or a question, don't hesitate to pick up the phone and call. It's free. Patient advocacy. That's my colleague Erin Acero, who's our VP of Global Advocacy, and Megan Busby, who's the Director of U.S. Advocacy. And then you've all met Amy, the really bubbly girl, blonde hair. She's our grassroots liaison who's gone out there and gotten 27 states passed the oral parity bill. So these people are working really hard to make sure that whatever drug your doctor prescribes, you're going to get coverage for. So this is a really, really important thing. If you're not involved with advocacy, you really should, because if not you, who? There's Amy and Zena, and like I said, they're doing an incredible, incredible job in making sure that every state in this country has equal access for all the patients. So they also formed PEAK, which is the Patients Equal Access Coalition, and SPEAK, which is the State Patients Equal Access Coalition. So get with Amy, find out more about these important coalitions and how you can become involved as an advocate. And Erin also started the Global Myeloma Alliance, where we're now working with organizations in countries around the world, because myeloma is a global problem and it's going to take a global fix, so we all need to be working together. So, where are we besides Boca? Well, we're on Twitter. A new thing that we have, excuse me, I get choked up about IMF TV. IMF TV, okay, everybody's on YouTube. This is a way that we can get information out to you in a really good format that everybody likes. So there are videos covering a whole broad range of topics. We're also on Facebook. There's blogs, webinars, webcasts, all kinds of things. Vodka this early? Thanks, Amy. No, gin would have a little bit of color to it. I'd be busted. The website. Okay, our website is amazing, and I want to tell you that we're going to go through a whole new website redo. Our site, you know, is getting a little old now, so we're going to have a whole new site that's going to make it so much easier to navigate. But even the site that we have, as you can see, is really, really experiencing a huge amount of traffic. Almost 2 million visits this past year. And the interesting thing to note is almost 59% of these visitors are new, which is really great. So when somebody gets the diagnosis of myeloma, they're going to our site and they're getting all kinds of great information and knowing that they're not alone. Interesting, we decided to say, well, where are these people coming in from? All over the world. And if you just look and see where, I mean, it really is incredible that no matter where people are in the world, this really proves that we are global, they're coming to our site. So you see from that area, I'm wondering about Peru. We've got to pick up the numbers in Peru. 1604 just isn't cutting it. But it is amazing. This is our reach. Just going to let you focus on those numbers. It's amazing, isn't it? Slovakia, too. Got to get that up. Oh, that's right. Forgot about that. Small detail. So one of the things that we have on our site, how many people have been going to look at the 12 steps to better care, 10 steps to better care? 12-step is a different thing. That's that. So this is an idea that Dr. Durie came up with, and this has been incredibly, incredibly popular and successful. It's really a great tool. So when you click on one of the steps, whether you're a patient, a nurse, or a physician, there are papers there and information that are fantastic. So you can see that it's really interesting that tests seem to be the most active part of the 10 steps. But this is something to go on and make sure your doctor knows about this. This is a really great tool. The Myeloma Minute. How many people here subscribe to the Myeloma Minute? Okay, all of you should. It's really great. It does come out weekly now. I know there was a time back a few years ago when it didn't, but it's fantastic. There's something for everybody. Go to the Myeloma Minute. It's your way of staying up to date on everything. The Myeloma Post. It's on iPad, iPhone, and Mike, is it on Android? And on Android, and almost 33,000 people have downloaded it. This is great, too. I all see you with your smartphone, so why don't you really get smart and download the Myeloma Post? One of the things that we started about a year ago was the IMWG conference series, Making Sense of Treatment. Now, all you guys come out to these seminars, but the hardest people to reach is the doctor that doesn't specialize in myeloma. He's an onc. He's treating a lot of different diseases. How do we get the information into their hands about everything that's new in myeloma? Well, one of the ways that we thought was to have a debate between top doctors. So you'll see there's Dr. Durie, Dr. Landgren, Dr. Joe McHale, and Dr. Antonio Palumbo from Italy. And these guys do this really lively debate, and it's fantastic. It's live streamed, and we tagged them onto a major medical meeting. In Amsterdam was the first one, Ash, Stockholm, and New Orleans. So we do these at the time of a meeting that's already existing, and they're incredible. They're fun, they're lively, and they're really a great way to get all the information. Like, they'll debate all the controversies, and it's really, really fantastic. I have to do a little joke. The first one we did, we had Dr. Durie and Paul Richards listed as the Americans against Jesus San Miguel and Antonio Palumbo. But the only thing is he's from Scotland, and Dr. Richardson is from England. So where were the Americans? I don't know, but it worked. Another thing, he's very busy, Dr. Durie. We decided to start this thing called Ask Dr. Durie. And how many of you have gone to the site and seen the Ask Dr. Durie? I have to say yes. They're fantastic. They're really, really great. And in the first 6 months, over 15,000 people have watched Ask Dr. Durie. And if you have a question that you want to ask Dr. Durie, just send it in to us. And then he'll answer it, and then you can go to Ask Dr. Durie and watch it. So in 2014, we want to launch Ask Dr. Durie Physician Edition, so that we can really make sure that all the practicing clinicians get their questions answered as well. So I talked about a little bit about IMF TV. So what is it? Well, it's going to bring you information in a new format. Top experts are going to discuss, debate, and present what's new in myeloma. And we're going to provide a platform for hot topics. They're going to discuss whatever controversies are going, breaking news, anything that's the latest and greatest that's happening. And if you have an idea of a topic that you'd like IMF TV to cover, just let me know. So we mentioned about Black Swan. So again, Dr. Durie, I think, will be talking more about it in his presentation. But I think the most amazing thing is this sentence that says, we now have the ability to start curing a subset of patients. So we've brought together the most prestigious group of researchers. They've agreed to work collaboratively together. That in itself is probably the most, if we never cured myeloma and we just brought these guys together and they collaborated, that would be a big deal. But they are working, and we are going to start curing people, so that's really, really fantastic. And this is my team. Thank you so much for your attention. So now I'd like to ask Amy to come. Yes, sir? You have a question?
Of course. What do you do with this media once you generate it?
Oh, nothing. No, seriously. Okay, so no, we used to do that. This is going to go onto our website, and so that anybody who wasn't able to attend the seminar is going to be able to view the seminar on our site and get all the same information that you people are getting this weekend just by being here. So we always film one seminar a year, and this is it. Okay, so now Amy, would you like to come up?
Thank you, Susie. Thank you so much.
You're welcome.
For everything. Hi, everybody. I'm Amy, as Susie said, with the Advocacy Department, and who knows what month it is? It is. It's Myeloma Awareness Month. Woohoo! Today's the first day, and we have a special guest today with us. City Council member Mike Muley is going to present a proclamation from the city of Boca Raton for Myeloma Awareness Month. So, Councilmember Muley, you want to come on up here to our lovely support group leaders, Dawn and Gail.
Sure.
Okay. I'm good.
We were supposed to, I think we were supposed to show quicker reaction than we did, but we tried. And yes, I am Mike Muley, a member of the Boca Raton City Council, and I do have here a proclamation that I'd like to read to you. First of all, I want to make sure we welcome you to Boca Raton and recognize that it's a large group coming to a meeting. Now, many people here, of course, are from South Florida, and I met a number of you here, but the other secret that you have uncovered is if you want to have a seminar that people will attend at the end of February and beginning of March, have it in Boca. Now, we of course are aware of the real seriousness of myeloma, so here's the proclamation. Whereas multiple myeloma, the second most common blood cancer worldwide, is a cancer of plasma cells in the bone marrow that affects more than 100,000 people in the United States, with an estimated 20,000 new cases diagnosed each year and 10,000 losing their battle with the disease annually. And whereas myeloma is a rare disease, often leading to delayed diagnosis and treatment, and increasingly being found in people under the age of 65. And whereas an increasing awareness of myeloma among clinicians and the general public has led to earlier diagnosis, allowing people to live longer. And whereas although there have been improved advances in the last decade, there's still no cure for myeloma. And whereas continued investment in innovation is critical to achieving early diagnosis and implementing the most effective and safest treatment for myeloma patients. Now, therefore, I, Susan Welshel, Mayor of the City of Boca Raton, Florida, do hereby proclaim March 2014 as Myeloma Awareness Month in Boca Raton and encourage all residents to join in the efforts to increase awareness of this cancer and to support myeloma education in the funding of research programs to find a cure. Thank you.
Thank you very much, Councilman Mike Millay. And also thank you to Annette, who's one of our support group members that was instrumental in getting this proclamation for us for the city of Boca Raton, and my co-leader, Gail Young. As a resident of Boca Raton since 1967, I wanted to thank the city of Boca Raton. This is the second year in a row that we have been awarded the proclamation for the city of Boca Raton. So I just wanted to thank everybody, and also to my wonderful group for getting proclamations throughout the county and also for 2 counties as well. Thank you.
And we have a pin for you to wear for Myeloma Awareness Month every day of March, so people can ask you
I will be very happy
about
to
what
do
is
that.
myeloma. Thank you so much.
Thank you.
We can get a picture. You're gonna fall again, I promise. I am coordinated.
Thank you.
Thank you. Thank you so much.
Good morning, everybody. So I'm here, I'm Mike Katz, and I think I met a lot of you yesterday. I was diagnosed with myeloma back in August of 1990, which was some time ago, and I'm very happy to still be here. Wanted to congratulate each and every one of you for being here, because coming to a seminar like this is one of the best things that you can do to really arm yourself to fight the battle with myeloma. And it takes some courage to come out and be out and about and meet people. But I think once you get here, you find out that there are hundreds of people and they all look pretty normal and they're doing pretty well. And isn't that a great thing? So I'm here to introduce the interactive segment of the program. During the day, we'll be asking questions of you and asking you to respond using the keypads that are on the tables. So first, we wanted to make sure that everyone has a keypad. And what we're doing is, you should have a keypad to represent every patient who's represented in the room. So if you're a patient and you're here with a caregiver, you should have one keypad, because that's what you'll be answering for. So if everyone can look and make sure they've got a keypad. Anyone who doesn't have a keypad, raise your hand and we'll have someone bring one over to you. Then they'll vote on behalf of the patient. They should take a keypad. So anyone, we have our lovely assistants running through the crowd. I see someone over here needs one. Anyone else not have? Everyone got a keypad? Okay. All right, so everyone set? Yes? Now, one thing to note, these are really easy to misplace, drop by accident into your pocket, into your pocketbook. They're useless outside of this room, and they cost us about $100 to replace, so please be sure to put them back on the table when you're done with them. So we'd like to get started to make sure everyone knows how to use the keypads properly. And those of you who've seen me do this before know that, I've got a terrible gag slide to start with, so we'll dispense with the preamble and ask you the first question. So which of my grandchildren's the cutest? Now, the way that you do this is you press the number for the one that you'd like, and your keypad a little green light will go on. And when the green light goes off, that means your vote's been counted. If you change your mind before the vote is over, you can just pick another number and it'll replace your vote. Say again? Well, the twins you can vote individually because they're not identical, so they do all look different. So this first vote's important because we get a count of how many people are going to be pressing, so please do vote on this first question. Yeah, Ruthie. 83, okay. Still people voting. 86. $91, okay. Okay, I think we'll call it at 91. Okay, so 56% can't pick, and the rest is really just split across the board. Okay. I think that's a good vote. I'll take that. Okay. All right, next question. Is this your first seminar? Vote 1 for yes, 2 for no. Now you're doing it fast. You've gotten the hang of it. It's not true what they say about you guys. Okay. So if three-quarters of you have had a seminar before, very good. Where do you live? So just indicate by picking the number closest to where you live. Any of you guys having trouble reading the map, just ask your wife. We're going to have a big run for number 2, 80% as usual. And the rest of them coming from, looks like New York and environs around there. How old are you? Now, this is anonymous. So 1 for less than 30, 2 for 30 to 39, 3, 40 to 49, 4, 50 to 59, 5, 60 to 69, and 6 if you're older than 70. Oh, almost half over 70, wow. You guys don't look it. Okay, so what was it that brought you to the doctor at the time of your diagnosis? It's a long laundry list, so I'm not going to read it. But you've got basically reasons 1 through 8, and then you vote 9 if it's some combination. People are thinking about this one a little more. Okay, we'll call it. So, pretty typical bone pain, the leading one, routine physical following that, that's changed over the years, and that a lot more of the general practitioners and internists are picking up myeloma and routine physicals than we've ever seen. But bone pain's always been a really big one. How long ago were you diagnosed? 1 if it was less than 6 months ago, 2 if it was 6 to 12 months, 3 if it was 1 to 2 years, 4, 2 to 5 years, or 5 longer than 5 years. Wow, okay, so you've got really 46, 80, 60, about 3/4 that are out more than 2 years, and almost 1/3 of you out more than 5 years. And like 10% less than a year. Great. Have you ever been diagnosed with another cancer, not skin cancer though, because that's just a layup down here. So 1, if you haven't been, 2, if you've had some other cancer diagnosis before you were diagnosed with myeloma, and 3, if you were diagnosed with another cancer after the myeloma. Okay, so that's only 20% with another cancer diagnosis, so that's a good thing. Interesting. Okay, and I think this is the last one coming up before the next segment. So if you were diagnosed with another cancer, so this is only the 20% of you who said you were diagnosed with another cancer. Was it a blood cancer, number 1, or 2, a solid tumor like breast cancer or prostate cancer and the like? So this is only for the people who both said they had been diagnosed with another cancer. So that number's about right, we'll call it. And most of the people had a solid tumor diagnosis. And I think we can go to the podium computer now.
Okay, before Dr. Durie gets started, can I just ask everybody to please turn your cell phones off, or if you need to have it on vibrate? And before I turn over to Dr. Durie, those papers that the cranes, that's $5. If everyone would fill that out and turn it in, it's like a $5 bill sitting on the table. Okay, thanks.
All right, so thank you, Michael. It's always helpful. Yeah. And there are going to be questions after different presentations during the day, so you're going to be to see that. And it's helpful to see what is the pattern of answers for all of you in the room. For example, it's helpful to know that a number of you have been to a previous seminar, what your major problems were when the myeloma first presented. So this first talk, even although many of you have had myeloma for a number of years and you've been to a previous seminar, I realized that it's helpful just to go over some of the basics about how we diagnose, monitor, and treat myeloma. And it was evident from the discussion yesterday, it's not so easy just to keep track of myeloma. It's not a simple disease. You start off where you've never heard of it, and then you have to have a speed learning to try and understand what are the details of this disease. A little bit crazy sometimes. So there are aspects which are new about myeloma over the years, and so what about in 2014? What are the aspects that we're particularly focused on and that we'll be talking about perhaps a little bit more in this seminar versus what we might have done in the past? Well, there's certainly a focus on earlier diagnosis, and 23% of you were actually diagnosed just from routine testing. And this is a pattern of the disease right now, that many patients are picked up when they really don't have much in the way of symptoms. And so when we're looking at treatment options, it's especially important to have treatment that works, but doesn't actually make you sick. You're not feeling sick, and so we certainly want to give you the best treatment, but we don't want you to be having treatment that really is having a lot of side effects. It's increasingly important to understand what are the best tests. We have new tests coming along all the time. How do you use these tests? Which ones are the best? And then based on those, what is the best treatment in your case? And we're going to be talking about that. And the main thing, I would say, the overarching idea right now, which is evident in the room here, is that increasingly myeloma patients are living longer. And so we used to be focused on getting the myeloma to respond to that first treatment. But now, 95%, 100% of the time, we can pretty much be secure that we will find a treatment that's going to work. We're more focused on how can we maintain that response, how can we have the best long-term outcome. We plan the initial therapy, we maintain the response, and then we also plan that over time, we quite probably will be giving new treatments to achieve a new response. We're looking at that longer-term outcome as a major goal. And then, as you just heard, and we'll talk about it myself and Dr. Landgren, who's coming up after me, how are we focused on trying to do the very best for some patients and hopefully start to achieve cure? You saw this slide already, but it is a simple way to target the area of questions that is most important for you. And so you can see on this slide that many patients are especially interested in tests. You know, what are the most important tests? To be sure about the diagnosis, to be sure about what are the best tests. So out of all these different people who've gone to the site, you can see a lot have been most interested in this. Initial treatment options, and then all the way down to the bottom. Obviously, if you've gone through a lot of treatment, there's tremendous interest in where are the new trials, which are the most important new trials. So, a helpful way to think about myeloma, and this is a a comparison that's been made for a number of years, starting with Maury Gertz from the Mayo Clinic. Having myeloma is kind of like having weeds in the garden. Instead of having a beautiful garden with different flowers, red flowers and white flowers, you've got this, kind of like our garden out the back, you know. No, we have a gardener, so it's good. It's trending between these two. But the concept is that if you do have weeds, then you do need to use some kind of chemicals or something to get rid of the weeds. And so the weeds are displacing what should be there. Instead of having the red and the white flowers, it's just replaced with weeds. And so as it regards to myeloma, when you have a normal bone marrow, you have cells, a mixture of cells which are producing red cells, white cells, and then the big ones there are actually making platelets. And so you have a mixture of cells in the bone marrow normally making normal blood cells. Instead of that, when you have myeloma, the bone marrow is filled up with these cells here, which are plasma cells. Plasma cells which are abnormal and are reproducing abnormally, we call those myeloma cells. So those are basically the same cells. Plasma cells which are abnormal, we call those myeloma cells. And if those are filling up the marrow instead of the normal red cell and white cell producing cells, then one of the first things that might happen is that you might get to be anemic, because those cells are displacing the red cells, and so you have fewer red cells, and so then you could become anemic. And so this expansion, this growth and buildup of the myeloma cells in the bone marrow is what creates what we call the Crab features. And so these are the characteristic features of myeloma when it's active. And so Crab is short for 4 things. C is calcium, and so if the weeds are growing in the bone marrow, they can destroy the bone around the marrow, which releases calcium into the blood. If the myeloma cells are producing protein, and the myeloma cells characteristically produce a myeloma protein, a monoclonal myeloma protein, because you have a buildup of all of these cells which are the same. They're part of a monoclonal growth of plasma cells which produce the same myeloma or monoclonal protein. This protein comes into the bloodstream and travels to the kidney and can, in some cases, damage the kidney. Then, as I said already, if you have these cells, you don't have red cells, so that you could have anemia. You could also have low platelets or low white cells. And, of course, if the myeloma is growing outwards, it can damage the bone, and so then you can get bone damage. And so you can end up with all or one of these Crab features. And in addition, you will be producing the monoclonal protein, which we can pick up in the blood or the urine. And so we are interested in what is the stage of your myeloma. And as we talked about yesterday, this myeloma, which has Crab features, has been developing from an earlier stage. And we know that this is a process that can occur over years, where you might have started out with something which we call an MGUS, where there's just a small buildup of plasma cells, but no Crab features. And over time, it can transition into what we call low-risk smoldering, higher-risk smoldering, and then a stage where it's almost myeloma, where there are like pre-Crab features, where the plasma cells are building up to a 60% level, where the free light level in the blood is building up, or whether there may be x-rays which are normal, but perhaps we're starting to see some changes on the MRI. And so this is a group of patients where we're looking seriously towards treating those like they have Crab features. Whereas at this end of the scale, we're looking to just continue to observe and not intervene, certainly not in an active way. And so you can see there's a transition from the green, a little bit of red, and then into a full red situation there. And so to understand what's happening there, you can start with a small lesion in the bone marrow. So you have a small buildup of plasma cells which can produce a small spike in the blood, which can then go over and might not be enough to damage the kidney or spill over into the urine. But if you have a larger collection of myeloma in the bone marrow, this is where you would have a larger spike in the blood. You might actually have calcium buildup in the blood, and then you might end up really damaging the kidneys and maybe having some spillover of protein in the urine. And so this is one of the key aspects about myeloma, which came up in the Q&A yesterday afternoon, is that we don't just look at one test. Myeloma is a little bit different than other diseases where you might just have the one test that you're tracking to see whether it's up or down. In myeloma, we're looking at 3 different kinds of things. Over here, we're looking at the bones. This is supposed to be the spine with the myeloma building up in the bone marrow. We can sample the bone marrow, which we do not do from the spine. We do it from the back of the pelvis. But myeloma is affecting the spine and the pelvis typically, along with sometimes ribs and other areas, obviously. But as the myeloma is building up, we can track what is the damage to the bones. But in addition to that, we can track what is the status of the myeloma. And so if there's a small spike, this would correspond to a small amount of myeloma in the bone marrow. What that means is that we don't need to be constantly sampling the bone marrow. If the spike is going down, this tells us the amount of myeloma in the bone marrow is also going down. So we can use the blood as an indicator. And the same is true of the kidney and the urine. If there's less protein, there's less kidney damage, and so the kidney function is going to improve, and there's going to be less protein in the urine as well. So we need the bones and the bone marrow, we need the blood, and we need to track the kidney. So, to track these CRAB features, these are the tests that you need to be tracking, and these are the ones that you might want to request copies from your doctor. It's really, really helpful for you to track your myeloma. So when you go in, ask the doctor or the nurse to give you copies. These tests are actually yours. It's actually a concession that you're making to the doctor that he also has a copy, you know. They are actually your test results. It's your blood, it's your urine, they're your test results. So you can get them. And so the blood is tested using a chemistry panel. CMP, L is normal. Gives you the calcium result. In the same chemistry panel, you get the serum creatinine, which we use to track the kidney function. You get a complete blood count, CBC, which tells you the hemoglobin, the white cells, and the platelets. A CBC, so you get a chemistry panel, a CBC, and then you're going to have x-rays and scans to see what's going on with your bones. If the x-rays are negative, you might have an MRI or a PET CT scan to see if there's any smaller lesions that we should be aware of. In addition, especially at diagnosis, you will have a bone marrow sampling test, which will be typically taken from the back of the pelvic bone to get the plasma cells and study them to see what's the percentage and what are the chromosome test results. We look at what's called FISH. It's a fluorescent stain which stains the chromosomes different colors, so we can see if the chromosomes are there and if they're mixed up in any way using this FISH test. It truly is like a fishing expedition to find out what's going on with your chromosomes. And then we check the blood and the urine, the serum protein electrophoresis, the urine protein electrophoresis, the quantitative immunoglobulins, and immunofixation. So those are the 4 testings that are done in the blood and the urine to track the amount of the myeloma protein. So this basically is a summary of the testing that you need to diagnose and track myeloma. So what does myeloma look like? Well, when you have that protein in the blood, it shows up as a monoclonal spike on what's called the SPEP. And so this is IgG. Typically, there's a spike like this that shows up on this electrophoresis test, and we measure basically how high is this spike. For IgA, it moves a little bit over to the side here, and it may not be so easy to see the spike, and so we may actually not track the IgA using SPEP. we may just measure the direct amount of IgA using what we call QIG, the quantitative immunoglobulin. So for IgA, we might not always use the SPEP. Then obviously, initially we will do a bone marrow, but hopefully we don't need to repeat that too often. The images of the bones are very important. X-rays, increasingly we're using other kinds of imaging, particularly MRI, which can allow us to see lesions even if the X-rays may not show too much. And so, for example, this just shows you an MRI of the spine here. And if you have lesions in the spine, with this particular method, the lesions show up as white spots, and you can see there's areas of damage. Using a PET scan, which picks up the sugar uptake into the lesions, you can use this particular setting to have the sugar uptake show as a yellow spot. And this is a lot easier to see that there are areas of sugar uptake in quite a number of the vertebrae in the back of this particular patient. So several areas of spots of myeloma, which is why we call it multiple myeloma. There are multiple areas which are affected by those spots of myeloma in the bone vertebra. And this here shows you where you can scan the whole body with a PET scan. This just shows it in a black and white way. This is the same as the yellow and the red. Here, the yellow is just showing up as black spots. And you can see here there's one in the breastbone, a number in the spine, a number in different spots in the ribs in different places. And so this is very, very helpful to see where there are spots, and particularly over time to see if they've gone away, which they frequently will, rapidly with treatment. And so these kinds of scans, MRI, PET-CT scans, very helpful initially to assess if you have some kind of special problems, particularly if the X-rays are negative. So it can diagnose active myeloma where we might be uncertain, do you actually have active bone damage or not? And they're very, very important to see if the disease has gone away, if there's any disease left, and also with monitoring if there's any disease coming back, if you're on maintenance or just having follow-up off treatment. Now, how do we actually calculate the level of the myeloma protein? And I've just put some numbers on here just as an example. The myeloma protein contributes to the total protein in the blood. And so many times myeloma is picked up. When the chemistry panel is run, the total protein is increased. So this is a number of 10 here, which is abnormal. Normally the protein level runs up to about 7, 7.5. So 10 is high. When the total protein is high, within that there is the myeloma protein, the myeloma spike. In this case, the spike represents 30% of the total, so the myeloma spike is 3 grams, 10%, 30%, excuse me. When the abnormal protein goes up, the normal protein, which is the albumin here, goes down. This is the albumin. So the albumin represents 24% of the total, so it's 2.5. So that with myeloma, the spike goes up and the albumin goes down. And so this tells you the amount of the protein. We also use this other test, immunofixation, which tells us the type of the protein. Is it IgG? Is it IgA? Is it kappa or lambda? So using the immunofixation, which we do at the beginning, tells us, do you have an IgG, an IgA, a kappa or a lambda light chain only, perhaps? And so we put together a collection of tests which tell us about your particular disease. In the bone marrow, we would do the FISH test. This shows you the FISH chromosomes. You'll see all the different chromosomes are different colors here. We look at this view right here where we can see them showing up as spots. And you can see here, normally you have 2 chromosomes. Like number 4 here, number 4 is green. But you see here, there's a green and then there's a red. Number 14 is red. So here what you've got is a mix-up of number 4 and number 14. You've got a red and a green, which means that we have what we call this 4-14 translocation, where the 4 is mixed up with the 14. And you can tell that by seeing that the 2 colors are right together. So you can see that by looking down the microscope. Over here, we can see which genes are turned on using a gene expression. So if the genes are active, this test turns red. If they're not active, it turns green. If the myeloma is what we call a high risk, where it's more likely to be difficult to treat, then we have a pattern where certain genes are turned on and red in this picture. And so you can look at 70 genes, and this can give you a clue as to whether it's high risk or low risk. This is something that's not done routinely, but it's something that we're using to understand more about this. So what we do right now is we use what's called ISS staging. And this is a helpful thing for you all to be aware of, to see what was your ISS stage at the beginning. And this is based upon the albumin. As I told you, when the myeloma is active, the albumin goes down. So if the albumin is low, this indicates a higher stage. The beta-2 microglobulin goes up at the same time as the IgG or the IgA goes up. So active myeloma is associated with a higher beta-2 and a lower albumin. And this you can use to end up with 3 stages, where, for example, the stage 3 is where the beta-2 is above 5.5. And so you can have 3 stages, and then you can combine that with the fish. And so what you can see here is, and this is with old data actually, but you can see here, if the beta-2 is low and the albumin is normal, and the fish testing is completely normal, it doesn't show any mix-up of those colors, then you can see here that a high percentage of the patients are doing well at 10 years. See, this goes out to 10 years, this goes out to 15 years. So this gives us a very good idea right from the outset what to expect. And as you'll hear probably from Dr. Kumar, these numbers are improving all the time as we get better and better initial frontline therapies. But this gives us a clue where you fall in the spectrum of myeloma. And this also shows where we are looking in terms of managing the disease. MGUS, we're still following. Smoldering myeloma, if you fall into a high-risk group, we may consider treating you as if you have early active myeloma, because we're concerned that you might be going to develop Crab features soon. And these are the features that we're looking for: the plasma cells 60%, free light above 100 milligrams per deciliter, and some kind of positive imaging. A key thing which you can tell from looking around the room is that each patient is different. There are different types. Somebody could have IgG, somebody could have kappa or lambda. You could have all of the Crab features, or you might just have one of the Crab features. You might be older or younger. In this group here, mostly people are in the 65 or older group. You might have an early stage or a later stage, abnormal fish, abnormal PET scans or not. So each of these things means that we need to think about the treatment individually in your case. We're going to be looking at the stage of the disease using a clinical staging system that I developed years ago, using this ISS system, and then looking in quite a bit of detail at these fish test results and the chromosomes to try to see if they would indicate a need for one therapy versus another. Mostly, if the chromosomes are abnormal, we're more inclined to consider a Velcade type combination, possibly a 3-drug regimen versus a 2-drug regimen. We're going to be talking to you, and you're going to hear about, should you be thinking about having a transplant, even although you may be a little bit older or maybe not? What are the prognostic factors in your case? It's really important to press your doctor to get as many of these different test results that I've been giving to you as possible, so you know this information in your own case. Now, when we're talking about therapy, as I said, mostly we can offer you therapy that is probably going to work and probably work pretty well. And so many times we're talking about a balance between having the treatment work, but keeping you out of trouble. We want to avoid neuropathy. So we may talk about Velcade once a week, Velcade sub-Q. Consider carfilzomib if you've developed neuropathy with Velcade. Obviously, Dex. Your wife may come in to talk to the doctor about that one. See if there's any way the dose could be reduced, or maybe there could be treatment that doesn't include Dex, so that she doesn't move away back up to New York for a while. Blood clots are a problem with some of these meds, especially what we call the IMiDs, thalidomide, Revlimid, pomalidomide. Aspirin might be used, or something stronger like a blood thinner. And obviously, infections are something that we always watch out for in patients with myeloma. But I would say that the big thing that is really key, and it's important initially, but actually, over time, as you start to realize that you have a serious disease, but here you are 6 months later, here you are a year later, here you are 5 years later. So instead of thinking, well, what am I going to do while I'm just dealing with this horrible situation, you can be functioning. You can be planning a new life where you are dealing with myeloma, but you're able to continue to play golf, go boating, go on vacations, do things that were in your initial plan for coming down to Florida. You didn't plan to come down to Florida to get myeloma. You came down to enjoy your life, to continue to enjoy your life. And so it's important to get beyond this point of trying to figure out the disease, get started on some treatment that's going to work. It just takes time. And also some adjustment to the fact that you have to focus on the disease, but you need to refocus on getting on with your life as best you can. And so it takes time. Initially, you may think, oh my God, I'm never going to get through this. But over time, that little spark of hope is that, actually, maybe I am starting to feel better. Maybe the side effects are not what I thought. I did actually get through the stem cell and I'm still here. I am managing to get along with the treatment for this disease. And you need to pay attention just to your life overall. The treatment's going to work better if you pay attention day to day, if you're getting proper sleep, watching to reduce stress. Getting sleep can help with weight. If you're sleeping, you're not eating. You can go on trips. Yeah, think about that, yeah. It's actually true. I don't know quite why it is, but when you get regular sleep, it does seem to affect your metabolism. But it could be that you're just not eating. Anyway, exercise is good. It maintains the bone density, but also it allows you to become more active again, and the idea is that we do want you to become more active again. Eating, many patients are very, very anxious to make sure what should they be eating. Did you get myeloma because you were having French fries and Diet Pepsi? Well, maybe. But I think that it is important to focus on eating real food, homemade, if possible, unprocessed ingredients. This is a particularly good book, by the way, by Nina here. I've also done quite a few blogs on this topic. If you're actually interested in food, you can go to Myeloma Post, and you'll see different things that I've written about the pros and cons of eating and drinking. Not gin. Red wine could be good, though.
Any recommended dosage on the red wine?
Yes, not too much. Not too much. A glass a day, perhaps. It has been studied a little bit, but certainly not too much. And so I'm not going to go through this too much, but it's important to focus on food that your grandmother might have recognized, or even your great-grandmother, where they didn't have processed cheese and processed this, that, and the other. They were actually eating food that came from the fields and was not hydrogenated or cold-pressed. So think about it. Be careful about supplements. About 60 to 80% of you are taking some kind of vitamins and supplements. really important to let your doctor know because some of these could be interfering with your treatment. So please be aware of that. There's a temptation to be taking a lot of different stuff, but please, that could be a negative. And if you're eating properly, it may be that you don't need to be taking so much extra vitamins and the like. Try to reduce stress. Having myeloma is stressful enough, but get rid of things which really stress you. You know, have the grandmother move out. No. Whatever it is, I did have one lady who said that she was just so stressed. She went to work one day, closed the door, and she never did come back. She said that was the best thing she ever did. But that was extreme. What you're going to hear coming up after me is a talk about ways that we can study myeloma and come up with therapies that maybe could end up curing myeloma. And this is the focus of what we call the Black Swan Research Initiative. And as Susie said, this is an approach where we're trying to use new drug combinations at the right time and for the right patients and monitor the amount of the disease. And this is something you're going to be hearing a lot more about. Residual disease, minimal residual disease. We're trying to push the myeloma to a low level to get minimal residual disease, maybe even MRD 0. And so we are looking at tests that will allow us to do that. And so this MRD testing, we're looking at a test, one of the tests we're looking at is what we call a flow test, where we take your bone marrow or your blood and we put it through a flow machine to see, for example, is there 0, is there any myeloma left? In which case we could maybe stop treatment, which would be fantastic, or maybe we think that it's still important to intensify it and maintain, to keep it at 0. We could have a return to something that's MGUS, so there could be like some MGUS left which does not need treatment, so we might be able to stop. If we find some myeloma left, then we can decide what kind of new approaches could be useful to get rid of it. So this is sort of an overall strategy to stop, to maintain, maybe switch treatments to do a better job. To really do the best job, what you're going to hear about from Dr. Landgren is what can be accomplished if you start really early, if you start really before there are CRAB features possibly, even pre-CRAB. And the idea here is that as you move around this circle to get more advanced disease, some of the resistant clones, which are tiny to begin with, can build up. So you end up with cells which are resistant to the treatment. But if you start early, we hope that maybe over here we could actually get rid of those resistant cells before they have a chance to take over later. And so one big concept, if we have the confidence that treatment can work well, is to start early and really try to knock it out with sort of a preemptive strike over here. You're going to hear about that. Now, we found this picture recently, which was fun for Susie and I for 2 reasons. One, because it's a pretty crazy picture. This is a goat. This is a real picture of a goat climbing a cliff. Now, I knew that goats were agile. You know, I knew that they would climb up hills and stuff. But this guy, I'm not quite sure what he's doing with his tongue. But anyway, he's like climbing up this cliff here. Now, you may or may not know that the goat is the sign of Capricorns. And you may also not know that both myself and Susie are Capricorns. So we are actually goats. Now, we haven't been practicing this yet, but, but you know, it is amazing what you can do when you really try.
The mountain may be frozen.
Yes, yeah. Maybe he's stuck, yeah. Now, we don't want to give false expectations. I think that as we try to do a better job with therapy, obviously there's some patients that have abnormal chromosomes where we know it may be a while before we can do a substantially better job. But there are patients who are already doing well, living 5 years, 10 years, 15 years, and so we know that we might have an opportunity to push those patients towards a cure situation sooner rather than later. And so we have a targeted approach, a realistic approach, where, strangely enough, we might end up treating patients who have what we call good risk disease even a little bit more strongly to see if we can do an even better job. And so the Black Swan, we are very, very happy to be working on. You're going to hear more about it. But just to finish up, the one thing I want to emphasize about these meetings, and has been true over the last 21 years, as Susie said, we've been doing these meetings. Education is really important, but meeting each other, helping each other, finding a friend, finding someone that will support you, having your partner with you, to go forward together and have a joint plan and have the best outcome. This is one of the main things about coming together, where you can see people who've done well and try to do the best together for you and your partner. Thank you.
Just a little review on how we're going to do this. So myself, Suzanne, Debbie, and Kelly, we're each in a quadrant, and we're going to go around the room. So one from here, then Suzanne's section, Debbie's section, and Kelly's. We'll take as many questions as we can. If you don't get your question answered in this session, ask it in the next one.
So,
okay, so
what I can mention, I noticed that my colleagues have come into the room, so if I could ask Dr. Anderson, Dr. Stadmeyer, Dr. Kumar, and Dr. Lynch.
And Dr. Landgren.
Ola is here too? Yes. If you
Ola.
Ola.
Hola.
Yes, he just flew in from Spain. No, no. So if you can come up here, you can help us answer questions.
Okay, so who in this area? Okay, lady in the front row, right here.
Okay, my husband has a blocked tear duct and
Okay.
has had this blocked tear duct for a number of years. It is a chronic source of infection.
Yes.
They're having difficulty controlling it. The only thing that will stop it is to drill through the nasal bone and make an opening so the tears flow into the nasal passage.
Oh, my
Right
goodness.
now, he also has a papilloma in the corner of the eye, and this is all they suspect a result of the blocked tear duct. What kind of danger are we facing with drilling through the bone in the nose?
Right. Well, unfortunately, I didn't finish my ear, nose, and throat fellowship. But I would say that one thing is that myeloma rarely affects these bones that might be the basis for the surgery. So I don't think that there's probably a risk right in terms of the bones in the nose area would be the first thing. The second thing is, though, that I think it is especially important to try to get this settled, because you do not want to back up with chronic infection when you have myeloma. So I think that I would encourage you to get the best advice and to attempt to get it dealt with, you know, and don't hesitate. If there needs to be some drilling through the bone there to get it squared away, my sense is that that would be the thing to do to get it dealt with. Anybody here finish ENT fellowship? I don't know. I've actually not had, this is a unique problem to me,
So the problem is...
a blocked tear duct.
Oh, blocked tear duct, yeah.
I don't know, it's pretty unusual actually.
What I've been dealing with patients during this whole season with dryness, right? You know,
Yes.
with the humidity gets down so low when it's cool and you have dry air heat. And so this may, you know, so I don't know about this thing, but when I hear about clogged tear ducts and,
Yeah.
you know, and congestion, and one of the first things I always tell people, which is what I always tell people from the beginning, is drink your fluids, make sure you're well hydrated, make sure that
Right.
the rooms are humidified, and you know,
Yeah.
those sorts of things. So
Basic
just
things.
as basic things, but obviously for this particular issue, I don't know if we really have expertise.
Suzanne?
Yeah, it's always difficult to give specific recommendations without knowing the whole story, so that's why we should be careful. But in general, I would discuss with a doctor that you have an increased risk for infections, but the doctor should really clearly weigh the pro and cons and should avoid, any exacerbation of chronic infection. So if the
Right.
doctor thinks it's necessary, I would follow the recommendation, but discuss whether you need maybe antibiotics around the surgery or IVIG, for instance, to boost
Right.
you up a little bit. But
Or an
I
extended
would go
course of
ahead.
antibiotics or something like that. Yeah. Okay.
Next question over here, doctor.
Hi, when you show the image of the PET scan, and it's both severe and the focal, diffuse and focal disease, will anyone show myeloma all over their body like that, or only if they have bone disease?
Right. Well, myeloma mostly is multiple. In other words, we do have these different spots of different sizes in different places. This is a characteristic of the disease, which I know is kind of scary at first thought, where you can see that there are these multiple spots. But the good news is that the treatment travels through the bloodstream, and when you do the follow-up scan, you see that all those multiple spots have frequently gone away. And so the multiple spots are typical for the disease, I would say. Yeah? Yeah, go ahead. All right, Debbie first.
I always say they didn't see the woman.
I can't see because I'm blinded by the light, but
You're talking into the, you need the microphone, Debbie. And he took it.
all right. Speak into the yellow card, yeah.
You're not even blonde, Debbie. What happened?
Okay.
Teleconference. You
Right.
mentioned touched on various chronic infections led to different types of
Right.
myeloma. Is there any chance you could expand on that?
Okay, so maybe you guys could comment on this. So that I gave a post-ASH teleconference, and I mentioned an abstract from ASH, which was from the NANT group. And I don't know if you guys even saw this, but the NANT team with Philippe Moreau and someone working in his lab, they studied the myeloma M component, and they found that 27% of them had a specificity against infection of different types using a heteroimmunofixation method. And so they found there was specificity against EBV, hepatitis C, and H. pylori. And so this raised the question of, is the clone which gives rise to MGUS, smoldering, and myeloma, is it derived from a reaction to some kind of an infection? And so I don't know if anyone, Ola, you want to comment on that? I know you've had some interest.
That's a difficult question. A lot of research has been going on in various hematologic malignancies, myeloma, leukemias, and lymphomas, etc. But people have tried to link it with different types of antigens that could trigger the development. I've not read this abstract in full details. I don't know exactly what they have done, but I guess the theory is, as you just said, Brian, that these agents maybe could be the triggers, and looking for these fingerprints in these proteins and linking them back to what these infections look like, that kind of provides some evidence. But I think you need to do more studies. So there is evidence from different studies that infectious and other types of antigenic agents could potentially trigger, but for now, I think it's a fair statement to say that these are hypotheses that need to be tested and verified in more detailed studies.
Ken, you want to comment?
Yeah, I would just echo that. I think this is not a new observation at all. For a long time, when you look at the M protein that each of you has, there has been the ability to say that that M protein, which is what Brian and Ola are saying, reacts against, in some cases, bacteria, in some cases, anti-thyroid antibody, in some cases, antibody to HIV has been reported. Antibody against the myelin coating of nerves has been reported. So the antibodies that M proteins, most of the time we don't know what they react against, but they can react against a variety of things. That's a long way from saying that we have an infection causing myeloma. That we should not convey. In fact, some of us are old enough to remember when more than once it's been reported that a virus causes myeloma, which turns out not to be true. So I think it is interesting. We need to understand I think it tells us more than anything else is that the genes that are responsible for that antibody response are in a pattern that suggests that they can react against the bacteria or some of these other things. It tells us where in the differentiation of a B cell the reaction occurred or the rearrangement occurred that resulted in this M protein production. But I think, it's true, but not causative right now. So I just wanted to say that because I don't think we want to leave with an idea that infection is causing myeloma, right?
Yeah, it's the first time that this had come up at a recent meeting, so that's why I just mentioned it. Okay. Okay, go ahead.
Children and grandchildren, are there any studies saying whether or not they're more possibly likely to get myeloma, and if so, what precautions or tests should be taken?
Okay, so Ola, I think probably you're the main person among us who's published on this recently. You want to comment?
Yeah, we did studies in Scandinavia. In Scandinavia, you have access to these population registries that cover the entire the population. So we pulled out all individuals diagnosed with myeloma from 1958 up to present date, and then you could link them back with the multi-generational registry, and you could link any person who was alive in the year of 1932, and then you could look in those people and see if any of those individuals had myeloma. So that's a very powerful way of looking at it. And if you do it that way, you see that family members have a twofold higher rate of myeloma, and that sounds very high. Now, very, very important what I'm going to say now. The absolute risk of myeloma is extremely low. It's 6 people per 100,000 in the population. So if you double that risk, we're talking about 12 people per 100,000. So in absolute numbers, the risk is minimal. It's close to zero in reality. So statistically speaking, it's twofold, but absolutely speaking, it is not of major relevance. So I think that's a very important message. And we did the same exercise for MGUS, and we showed the same thing. And we also looked in MGUS people for myeloma and myeloma for MGUS. So you see the same thing. There is a relative increase, but the absolute increase is not there. And Mayo Clinic has replicated these findings. So I think that those data are pretty solid.
Right. So there's a risk, but pretty low. Yes. We can actually do something here. If you ask people with myeloma if there's another close family member who has also had myeloma, the answer to that question is yes, about 5% of the time. So it's a low percentage. So maybe we could do that right here. Of the people, myeloma patients in the audience, how many of you have another family member, a sister, a brother, or a mother, or someone else who also had myeloma? You want to raise your hands? So, a few, not too many. Which is? Not myeloma, but it could be a related disease, yes. Anyway, it's relatively rare.
How about in this section? Anybody have a question?
My wife was diagnosed with multiple myeloma 4 years ago. She's had a number of skeletal x-rays, over the years, like an annual one every year, and they're never showing any lesions. Would you still suggest she have an MRI or PET scan?
Yes. Actually, maybe, Suzanne, you'd like to touch on this. I know you have a particular interest in this type of screening evaluation.
Right. Again, I mean, it depends on the clinical situation. If your wife is completely stable and has no evidence of disease progression and no symptoms, then I would say there's no reason. But if she has any evidence that there might be disease progression or increased pain, for instance, then I would go ahead and would probably use another method to detect lytic lesions, such as a CT scan, because that's much more sensitive than a skeletal survey. So we know that you have to lose almost 30 to 50% of your bone mass before a skeletal survey shows up a lytic lesion. So that's important to remember. So it's not a very sensitive method. But again, if your wife is doing fine and has no evidence of progression, I think just wait.
Right. But frequently at the time of diagnosis, you might do some testing other than the routine X-ray. Is that correct?
Right, that's correct. Yeah, I personally think that a skeletal survey as a gold standard to detect lytic lesions underdiagnoses our lytic lesions. I think that we need more better methods like, for instance, the CT. A PET CT very often is very expensive, but at least the CT scan should be kind of, used for the detection of lytic lesions.
Right. Okay.
Many people at our age walk around with a back pain. At what point do we ask our doctor to do a myeloma test?
You're asking when should people be screened to make sure that they have myeloma or not? Is that what you're asking? Okay, so how should we be evaluating or screening for myeloma? Let's say here in Florida, where you have people over the age of 65, what should we be doing as far as routine testing? Maybe Shaji, you want to take that one? Because they might be coming to the Mayo Clinic, for example.
So I think it kind of gets back to what Dr. Landgren mentioned about how infrequent this condition is if you take the whole population. So I mean, backache is not something that's uncommon, as you already mentioned. So we certainly don't want to be looking for myeloma in everyone with back pain. But if you think the back pain that doesn't go away with conservative measures, the typical things that we do for it, obviously, especially if the X-rays or any imaging studies show something abnormal, either in the bone marrow that you visualize using MRI, or there's some collapse of a vertebrae or something like that that gives you something more specific about myeloma, we should not be looking for it. So I think in the absence of, we certainly don't want to be going out and looking at everyone to see if there's any bad monoclonal protein in their blood, because I think that's going to be a very low yield exercise, and we're going to come up with more, getting more people worried about a tiny little protein than really identifying people with myeloma.
I think the importance is the awareness of myeloma in the community, as you have, and in the medical community. And by having that awareness, when you have a general checkup, you do tests and you do physical examinations, and myeloma can manifest itself by so many different ways. As long as you're aware that that's in the differential diagnosis of anemia or bone things, and with all the tests that we have, it is a relatively easy test to do, a blood test for serum protein, a urine test, that it's a combination of awareness and good general medical practice that will pick it up rather than screening specifically for it.
Yeah, not ignoring some of these minor anemia or protein problems. Okay, one last question from Debbie. Yeah, so you hold on to the yellow card, yeah.
What's wrong with it? Why can't you drink
Vitamin water.
Why do you say don't drink it?
So what kind of vitamins are in your water?
B6, B12, the B vitamins.
Okay. So someone want to answer a question about whether actually, Ed, you said that people should be drinking water. How about vitamin water?
Well, I mean, did you mention something about not?
Well, what I said was...
It's all because of Brian. Is that the problem? Okay. Well, I'm always trying to put out Brian's fires. That's the problem. No, I don't think that I would guess that he did not say specifically don't drink vitamin water.
No. He actually
did. I think what we usually say is
don't drink vitamin water.
Overcompensating with lots of vitamins. Sometimes if you take a large amount of even very good vitamins, that can actually give problems, like tons of vitamin C can sometimes hurt the kidneys, et cetera, et cetera. In terms of hydration, we talk about water, but plain old water is fine, but it's not really the key is to be well hydrated. So I think that water with stuff in it is actually good. I always tell bubamycin, chicken soup is certainly one of the best waters to take to keep yourself well hydrated. So there's nothing wrong with it. When we say hydration, we don't mean just plain water. It's fluid, having a good urine output, keeping well hydrated, those sorts of things.
There's some concern about vitamin C and some of the medications, especially the bortezomib, Velcade. So obviously, if somebody, we don't know how much of vitamin C someone needs to take before it might impact the effect of the treatment. So I think that's maybe one of the concerns that may have been.
Right, right. So that's the concern that I was trying to convey, is that vitamins, like in green tea, for example, contains chemicals that can interfere with Velcade, for example. And so just don't casually be taking extra vitamins and supplements.
Yeah, could I just add, I think for neuropathy, there are a variety of strategies that have been tried besides medicines, which treat the symptoms, and B vitamins, I think, have been important at many centers. The other thing, it's not unique to myeloma, but vitamin D deficiency is very, very common among all of us. And so I do think it's important, and there's evidence that vitamin D at normal levels is very useful, not only for health, but maybe even preventive for other cancers, colon cancer and other things. So vitamin D levels are very important to be measured. They're very important, it turns out, in bone biology too. So,
so I think these very specific suggestions, vitamins should not be taken casually. They should be taken in a specific way. Check your vitamin D level, see if it's low, and then take vitamin D replacement, which could well be required. Okay, I think we're going to stop there. So thank you guys for your comments. So I'd like to welcome Dr. Ola Landgren to the podium. And this is a special lecture which we don't normally have. We've had the Black Swan Research Initiative for about 2 years now. And so Dr. Ola Landgren is actually part of the Black Swan team. And in his group at the NIH, he has been studying a variety of things which are important in moving this field forward. So I'm very, very pleased to welcome Ola to give this special research presentation. Dr. Ola Landgren.
Thank you very
much. Before you get started, Ola,
oh my gosh.
I understand that today, does anybody have a light? But is today your birthday?
Yes, it is.
Oh my God. Well, hold on. Don't light. Why are you lighting it like that? That just.
There you go.
All right, everybody, you know the drill. What are we going to sing? Happy birthday
oh, thank you. Thank you.
Happy birthday to you. Happy birthday, dear Ola. Happy birthday to you.
Thank you. Should I blow?
Make a wish. Black Swan.
Thank you so much. Thank you.
Oh. We love you.
Thank
we
you.
love
I love you. Thank you so much.
Okay.
Well, thank you very, very much. That was really a surprise. Thank you so much. Oh, thank you very, very much for singing for me and for the cake there. I don't know, really. I probably lost balance there a little bit. I wasn't really expecting that. So it's really a great honor for me being here. I would like to thank Susie and Brian and the IMF for inviting me, and thank you very much, all of you. I was here last year, so this is my second year. This year I'm going to talk about the Black Swan Research Initiative. And I was invited by Susie and Brian to be on the team. And we have been working on minimal residual disease as one of the main topics. So that's what I'm going to talk about today. So I put together a presentation where I talk about these three topics: the major opportunity to improve myeloma outcome in 2014, and that will be with focus on MRD. I will then talk about MRD testing for myeloma in the United States today. So what's the current status of MRD testing in the US? And then last bullet will be, how do we move forward from here? And that's based on what you're going to see along the lines of the status of MRD testing in the US today. I think there is a lot of stuff that needs to be cleared up a little bit. So what we are seeing for patients that are diagnosed with myeloma in 2014 today, with different therapies, more and more patients are reaching a deep response. And this is a slide I borrowed from Dr. Kumar, showing that with different regimens over time, we see more and more people reaching a VGPR or better. And we presented at ASH that with the therapy CRD, carfilzomib Rev-Dex, that it was 90% VGPR or higher. And with RVD, it was around 80, and that will continue to be better and better outcomes. And you could, of course, add and do things so these numbers can keep on going up. So the message is that more and more patients are reaching deeper and deeper responses. The next argument I want to make is that the Spanish study, for example, has shown that with better responses, you also have better clinical outcomes. So for patients who reach a complete response, near complete response, they have a better outcome than patients that have only a stable disease or if you have progressive disease. And that has been found by other studies as well. The Spanish have furthermore looked into their patient population that reach a complete response and use more sensitive technologies. They have used their flow cytometry technology to determine whether that was detectable disease. And if you are CR and you're negative with their flow, they call that MRD negative. And what they have showed that in the group of people that reach CR, around 30% of patients are MRD negative with their tools. And they have a better outcome than those people that are CR that still have detectable MRD positivity. The last thing I want to say along these lines is that we used the same technology that the Spanish group did with flow, and we analyzed 8 color antibodies, meaning that we have a very high sensitivity for finding abnormal cells. And we also counted more than 3 million cells in the bone marrow, which is a lot of cells. And using this technology, we said if we find 20 or more cells being abnormal, we call that MRD positive. And then we looked in this group of patients that was treated with CRD, which I had on my very first slide. And I showed you that around 90% of patients reached VGPR or better. So if you only look in those patients who reached a CR, complete response, or a near complete response, even with this technology with flow cytometry, as you can see on this slide, they were all negative in the bone marrow. So that looks extremely promising. So now we have a situation where more and more people are reaching a deeper response with clinical standard criteria. And when we apply more sensitive technologies, we see that more and more people are also benefiting even higher beyond the standard criteria. And then we have the piece of information showing that the deep response translates into with a long-term benefit in terms of overall survival. So this is, of course, a major opportunity for us. So the next question is, how good are we at using this MRD testing in the US today? Because this is not yet standard. So in order to characterize what's going on, we just carried out a study just a few months ago, and it was published in the Blood Journal in 2013. So we sent out a survey to 30 major medical institutions, and they cover all the big institutions in the country. And within a week, 26 of them responded. So we sent this out by email to them. And we know all these people. And we said, we're not going to mention your institution or your name. It's going to be anonymous. But we want to ask you, and please be honest and answer these questions. So out of those 26 institutions, 19 of them said, we get more than 100 specimens per year from myeloma patients from the clinicians in our institution. 2 institutions said we have 50 to 100 specimens, and 5 of them, they didn't give any number. Interestingly, although there were 21 institutions, as you can see, who said more than 151 to 100, only 11 out of these 26 institutions said that they actually do MRD testing. So there are some institutions that do receive samples, but they don't do MRD testing. So out of 30, 26 answer, and 11 say, yes, we do MRD testing for myeloma in the US. We then asked them, and then we asked the lab people, what sample do you receive from the clinician? So when we do bone marrow biopsies, we do core biopsies and we do aspirates. And it's the aspirate that we use for this flow technology. When you go in and do an aspirate, you may not have a good yield all the time. So you may have to do another one or another one. You could do these aspirates multiple times to get sufficient number of cells. And for research purposes, And for diagnostic purposes, you may have to do multiple of those because you need them for different things. You need them for cytogenetics, you may need them for your genetic or for molecular tests in the research, and then eventually you may need a little bit for MOD testing. So you see on the left here is the first, second, and third, or we don't know. And what was a little bit surprising to us is that, as you can see on the right here, that out of the 11 institutions, that there were 3 labs, they didn't know which sample they got. There are 3 labs that got the third pool and 2 labs that got the second pool, and only 3 labs got the first pool. And I can tell you that the number of cells that you have in that aspirate drastically goes down after you have done your first pool. So you want to do the first pool because that's where you have the higher likelihood of finding these abnormal cells. And for all the labs, including those that do not do MOD testing, you see that 14 of them even don't know. We also ask these labs, what antibodies do you use when you look for MOD testing? How many do you use? So as you can see, 9 of them use 6 to 9 colors, and I would say that is probably the standard around the world at this point if you want to use flow cytometry in a sophisticated fashion. There were 2 institutions that only used 5 colors. And I know that this is a lot of detail, but I just want to give you a little bit of a feel of how the field is not really consistent here. So you don't have to, of course, remember all these details, but you see that there are a lot of markers listed here, and 1 institution has 1, 2 institutions has 3 of them, 2 institutions has another set, and 6 institutions has the last line here. And the point I want to make here is that there have been studies in Europe where the same sample was split into 2 and sent to 2 different institutions. And they were asked the same question, did you find abnormal cells or not? And then you compare those results. And the concordance rate between the answers, as you can see, is 67% for those 2 sets of markers, and it's 92% for the bottom line. So the last line is really the line you want to use. And that's only 6 out of the 11. Now I'm into a lot of details. I'm going to talk about less details in a second, but I again want to share with you some of the nuts and bolts here. So there is a panel of markers that you can look for. And there has been a recommendation by the European Myeloma Network. And in red, those markers are the markers that the network has defined to be critical. So I have a question here? Oh, I'm sorry, minimal residual disease. Minimal residual disease. Thank you for asking that. I apologize if that wasn't clear. I think I had it on my slide, but I didn't say it. Minimal residual disease. So in red, you see the markers that the network say you really should look for. And in green, those are the markers in the bottom that the network says you probably should look for. And when we ask these 11 laboratories, how does that pan out? You can see that 11 or 10 of the labs, they actually cover all the markers that are highlighted in red. But when we look at those markers that you probably should do on the very right on the top, there are only 3 labs that study many of them, and there are 5 and 9 labs that study some of the others. So the message I want to convey is that there are actually guidelines, but people don't follow them. And why is that important? It's because recent studies show that if you do a bone marrow on a completely healthy person, 30% of the plasma cells, they have features of, for example, being 19 and 45 negative. And if you only use 19 and 45 and you find that, you say, oh, this is abnormal. But 30% of normal cells have it, so it could be false abnormal. It's a false positive. And also, there could be plasma cells in the normal person that could be CD56 positive, and that's true in 15%. So there are false negatives and false positives, and the only way to get rid of those problems is to have a complete panel and to do it the right way. If you don't do it, you run into these problems. We also ask them, how do you process your samples? And there are different technologies for that. And the message here I want to convey is that, as you can see, 4 institutions do it in one way, and 7 institutions do it in the other way. And the way you do it is going to impact the number of cells you have left in your tube. So when you put that tube finally in the machine, of course, that's going to impact your results. So everybody has to process the samples the same way, and they don't. Lastly, we asked them, how many cells do you actually count? And what do you determine as positive and negative? And people do it very differently. So this slide summarizes the results from the 11 institutions. And as you can see on top, the institution that counted most events counted between 3 and 4 million cells in the bone marrow every time. And if they found 20, they called that positive. 20 or more, that was MRD positive. Minimal residual disease is present. And they used 12 antibodies to determine evidence of abnormal cells. So it's a very complete panel. At the same time in this series, the institution that gave us all the information for all the variables that allowed us to estimate what we call the maximum possible sensitivity, they counted 100,000 cells instead of 3 or more million. And they also used 20 as the cutoff. So if you multiply those variables, the likelihood of finding something varies by a factor of 100. So what does that mean in practical terms? So I do a very simple slide here to illustrate how this kind of impacts data. So I had one of my patients, a 53-year-old lady with myeloma. She had myeloma expressing, they were negative for CD19, negative for 45. They were dim for CD38, CD20 negative, 56 positive, CD81 negative, CD27 dim. So this is the complete panel. Now we did a bone marrow biopsy to see whether there were residual cells. We ran 3 million. We did an aspirate. We took out the cells. We processed by the guidelines, and we ran it in the machine. We let the machine count 3 million events, meaning 3 million cells. And as you can see on the slide on the very lower part here on the right, we found 30 abnormal plasma cells. So if you apply 20 as the cutoff, then you call that positive. Now we reset the computer. We had all the data in the computer, and we said to the computer, just go through the first 1 million cells and show us your results. So with 1 million, the first 1 million cells, now 12 cells are to be found. So if you use 20 as the cutoff, this patient is now MRD negative. We reset the computer, and we said, let's count 500,000 cells. Now there are 6 cells. And then we did the same thing with 100,000 cells. Now there is nothing. I think it's a fair statement to say that almost no doctor knows how his or her lab is doing this. There's no communication, really. And also the labs, they don't know what samples always they're analyzing, if it's the first or the second or the third pool. So there's a huge heterogeneity here. So if we want to develop these technologies, we need to do it the same way. I think this is a key next step. I also want to say that when we talk about minimal residual disease by flow cytometry, what we're doing is that we're looking for abnormal cells. And there are a lot of normal cells, of course, in the bone marrow. We have normal plasma cells, and there is a range of normal cells in the bone marrow microenvironment. And we use these machines where we label the cells with colors, and then we let them pass through a very thin tube where we have laser beams that shoot laser light on them, and then they emit color if they had the antibody connected to their surface. So we can then count every cell, and we can analyze every cell and see what colors actually attach to the surface. And this is the technology we use when we do minimal residual disease by flow. But you could theoretically envision that there could be other ways, of course, of doing it. So on the right here is a cartoon of a cell. Cells contain a lot of detailed pieces. And in the center of a cell, you have the nucleus. And in the nucleus, you have the DNA. And the DNA, when a cell breaks, leaks out in the body. And most things in the body end up, for example, in the blood. So you can find free circulating pieces of DNA in the blood. On the left here, I have made another cartoon where I highlighted the white pieces are DNA pieces from myeloma, while the green ones are DNA pieces from non-myeloma, which is the vast majority of cells in the body. So you could develop an assay where you look for the white ones. You look to see if they are there. So that would be a pretty neat test if you could do this type of exercise. And this actually is in development. There have been a lot of work in Europe and America for years trying to use what's called ASO-PCR, targeting a particular region in the DNA code. That's called the VDJ rearrangement, or the VDJ sequence. You can look for VDJ rearrangements. And without going into too many details, that is a region that is rearranged as different in plasma cells with myeloma compared to normal plasma cells. And it's also different from other cells in the body. So it's a reliable area to look. So the first technology here I've highlighted, I only have one slide talking about a lot of detail here. I didn't want to go into all the details with many, many slides. But the first thing I'm talking about here is that you have a set of markers that you apply, and if you find it, you find it. If you don't find it, you don't find it. But it's handy, and these markers, they do already exist. One of the problems with these markers is that only 70% of patients have abnormalities that these markers would capture. So it's a handy test, it's available, but it misses around 30% of cases. And there are a lot of issues also when you process the samples that you may ruin the sample. So when you actually run the test, there will be a lot of false negatives due to that. So in the optimal scenario, 30% would not be answerable, and you don't know who they are. But in the real world, that number is going to be higher because the test is a little bit too problematic to reproduce. You also have what's called high-throughput VDJ sequencing, which is something called deep sequencing, and we have worked a lot on that. You now sequence the entire regions. You don't have these markers that are predefined. You don't have the problem of missing 30%. You go through everything. The problem is with that technology that you have to pick your winner that you believe this is probably going to be the winner. But if you pick the wrong winner, in the end, you're doomed anyway. So you have a lot of information to begin with, but in the end, you're dependent on your decision that you made before. So it's a lot of work, and there is a random factor that you cannot really control for. The last thing here is what's called high-throughput exome sequencing, and now you sequence the entire genome. It's very expensive, takes a lot of time, and the technologies are not yet there. I think probably in the future, this is going to become the standard, but we are not yet there. So my personal, and this is my really personal opinion, I think these technologies probably will become the future. I personally think that it's going to take a few years till we are there. I think in a few years we're going to have these technologies hammered out, but I think there's a lot of work that needs to be done. This is a slide that mimics the slide that Brian showed just a few minutes ago, that there is an evolution of the disease in people that are being treated when the disease comes back. So you can see that there are subclones of disease. And there was actually a paper just a few weeks ago by the Boston group, by the Broad Institute. They looked through more than 200 patients with myeloma and found that people with myeloma have many clones to begin with. And that's what has been shown in this study and other studies. And we know that from smaller studies. But this study I'm talking about is the biggest study done so far. It's 200 or more patients. And it showed beautifully that there are multiple subclones. So when you treat, you get rid of some clones, but there may be some clones left. The reason I say that is because if you treat and you get rid of the disease, if the disease comes back, you don't know which of the clones that come back. So if you design these tests for MRD based on what you find in the beginning, that may not be what you have to deal with later. So that's a problem for people like me and the other speakers here today. When we develop tests, we have to be very, very open-minded and pick markers that are not inherently limited to what's the big problem to begin with. We have to think beyond that. And we have to have tests that can capture anything. So that's something that, to me, is one of the arguments where I think that there is more work to be done before the molecular tests are going to become clinical practice. That's my personal opinion. I highlighted a couple of factors here on the left, or aspects of samples that we are looking at. Sample analyze, if it's a universal assay, is it sensitive, is it reliable? Can you study evolution of disease? Do you have problem with sampling error? Does it vary if different people run the test? Do the results vary? And in my opinion, I highlighted here, I think we have to have an assay that's universal. Otherwise, we are not going to move the field forward. It has to be sensitive. Otherwise, it's meaningless. It has to be reliable. And it cannot vary too much when different people do it. And looking at flow on the right, I think that is a universal assay. It is sensitive. It's not perfect, but it's quite sensitive. It's reliable. The major problem with flow is that it varies if different people do it. And it's partly driven by the fact that people don't do the same thing. So if people were told what to do and they follow that, I think that could very much take away a lot of the variability. There are still things that methodologically would vary, but I think there's a lot of training that could take away a high degree of that problem. Lastly, along these lines, I want to say that I've talked about MRD with flow, I've talked about MRD with imaging, and talking about minimal residual disease without mentioning, I talked about flow and molecular, but talking about it without mentioning imaging would not be fair. I think imaging also potentially has a potential, and this is a study that was published from the Italian group a couple of years ago, showing that if you use SUV uptake for baseline with SUV uptake after therapy, if you wipe out the hot spots, that translates into better overall survival. I think that imaging has a lot of promise. I also think that imaging could be integrated with biopsies, so if there are remaining hot spots, maybe those could be biopsied and we could try to understand the biology of such. So I think imaging also has a future. So how do we move forward from here? I think it's fair to say in 2014, more and more myeloma patients achieve deeper responses to therapy. And I'm extremely happy to see that. I'm very, very happy. The field is moving forward very, very fast, and it looks really good. The second bullet here is that deeper responses usually translate into better outcomes. And I guess that's a pretty logical statement. And I did put a star here because it's not only about obtaining a complete response, always. I also said, in some patients, a deep response is not required for a good outcome. You can have a very good overall survival and a good quality of life and a good progression-free survival even without the CR. So there are exceptions to the rule, of course. I've seen it many, many times. You can have an M spike and it could still be there and just sits there, and that's not the big problem. If you were to go after that to wipe that out, it would be a lot of toxicity. It would not be justifiable to do it. So I'm not saying that everything should be reverted to zero. That is absolutely not my message. But I think for newly diagnosed patients, if we have the concept of minimal residual disease negativity, that could be an approach to go for a cure. And I think it could also be a way to monitor disease and make sure for patients that are being treated already that we have a tool to monitor and make sure that the disease does not get active again. So that's the message I want to convey. I also want to say that the flow cytometry-based minimal residual disease technology, it's already available. The technology is. The problem is not the technology, really. It's the fact that, as I showed you, that the testing by flow in myeloma varies greatly with a maximum possible sensitivity ranging from 0.0005 to 0.2. It varies with a factor of 100 because people do it differently. We need training. And also, I think these are probably a little bit bold statements here, but I think this is probably true. I think typically the doctor doesn't know how his or her lab defines negativity. I showed you the slide here with the example from my own patient, where we did the cutoffs with 3 million, 1 million, 500,000, and 100,000. And I also think it's a fair statement based on the data I shared with you that often the lab does not know which sample they analyze, and it's not fair to the lab. We need to work on these things. The procedures definitely need to be put together. So the technology is here, and we need consensus and standardized tools. And this is the last slide I have. The current Black Swan Research Initiative trial goals are to better understand the biology of the individual patient, and by understanding the individual patient's disease on a molecular biological level, then we can provide precision medicine. We can give the right drugs. We know myeloma is not one disease, so we need to really understand for the individual patient. The second bullet is, I think we need to work a little bit more also to identify the optimal time to start therapy based on, today we are using symptoms, but maybe there are biomarkers we should use. And we have been working, and the other speakers here in the room and other groups as well, on trying to see if we could develop trials for high-risk smoldering myeloma. I think that's an area where we need to work more and try to understand if that's the right way of going. And we have some very intriguing results. Also, after therapy, to rule out minimal residual disease, MRD, with the most sophisticated tests to optimize the outcomes. And that's what I've been spending most of my time today talking about. And lastly, based on all the above, trying to use all these pieces and collaborate and work to find a cure for myeloma. And I honestly think that working at institutions that are very powerful, we can do a lot of things, but without collaboration, we will never ever be able to move these things forward, trying to find a cure. We have to collaborate, and I think that the Black Swan Research Initiative plays a very important role, and IMF, to facilitate that. So I'm very grateful, and I really would like to thank Susie and Brian for having invited me to be part of that. That means a lot to me.
Thank you so much, Ola, for that elegant discussion about minimal residual disease and how we look to move this field forward. I think we have time for a few questions, so if our panelists would be willing to come back up, we'll take some questions from the audience. MRD, minimal residual disease.
Suze?
Or maybe coffee time now. I don't know. Go ahead. I'm not sure I heard completely.
No, so she asked if there's something that they can do as patients to ensure that in their doctor's offices that they're doing the test correctly.
Yeah, the bone marrow testing part.
Well, I think there are multiple things that I think we have to work together. So if you ask your doctor, and we try to communicate what I try to do today, that there is need for training, I think that's the only way forward. And I don't think it's anyone's fault. It's just a matter of trying to fill the gaps here. So there is really need for training here and trying to work out the consensus. I think a lot of doctors really, they don't know, but of course they would like to know, but they don't know where to start. So if you ask your doctor will ask the lab, and then that will kind of trigger the development. That's my take.
Right. So just to be aware, coming up in about 3 weeks, the IMF and the Black Swan Group are holding our first workshop to educate experts from the major groups from around the world to learn about a new standardized flow method that will include the details. So we're starting to build the information to roll out an educational program, starting with the technical aspects in the lab, but then rolling it out to some of the more practical details all the way out to the doctor's office. We're starting with the flow test because, as Ola said, even although it's not being done in a standardized way, the technology is there across the country. And so it's a practical place to start.
Debbie, in your area?
Yeah, go ahead.
Thank you, Doc, for all this. One clarification, please. When you talk about which bone marrow aspirate is submitted for flow cytometry and that often the MRD lab doesn't know which sample they analyze, is that timing, where in the therapy, the first, second, third? Are we talking about significant difference in...
No, it's the...
Yeah, so I want to clarify. So when you do the biopsy, you go in with a needle and you can do a core where you take out a chunk of the marrow. You can also do a syringe when you aspirate. And many times we do both. But when we aspirate, we don't want blood, we want cells. So we aspirate and we look to see how many cells we get, and then we maybe push those out, and then we aspirate a little bit more. And then we look, and maybe we do a third time because it's not enough. And every time you pull, you, relatively speaking, will have fewer and fewer cells. So if you were to do it 3 times in the same person at this very moment, the first time is where you're more likely to find cells. So if you're really looking for abnormal cells, you want to have the best sample for that. That's what I refer to. It's like at the same moment, but you do multiple of those and you push out the cells in the same side.
Ideally, the first sample is the best one with the most cells, the richest material.
Does that answer your question?
Yes, thank you. Here are two doctors over here. Which one of you?
Okay, go ahead.
Thank you so much for all your presentation as well as the research you're doing. My question is, at what stage in a patient do you, obviously when you first get diagnosed, you're going to have the marrow biopsy, but is there any recommendation so that as you go along, you get to benefit from the technology that you're saying is there? And so is there any recommendation in terms of when you would go and get?
Right. Yeah, so I don't, maybe if any of the panel would like to touch on this. So that obviously if you were going to be testing for MRD, you would do that periodically. Yeah, Shaji, you want to comment on this? How often would you be checking it?
So I think the first time we would check would be, where we expect that we would find a complete response, because that is what we've been using as our kind of trigger. So once patients don't have any protein that is detectable by the sensitive methods, like immunofixation, either in the urine or in the blood, that's a point where we would first do the bone marrow biopsy. And if at that point we find that, yes, we don't see very many plasma cells by the conventional methods, but the MRD is still positive, then I think, we would wait for a few more cycles of treatment and then recheck again. What number of cycles exactly, I think it's still kind of debated at this point. So.
Right. So I don't know if you want to comment. Obviously, what we've been talking about so far is bone marrow, but actually Shaji and others are looking at blood. It would be fantastic if we didn't need to be repeating the bone marrow and if we had a similar sensitive assay in the blood. You want to comment on the status of that, perhaps? What do you think about that?
Well, everyone would agree that if we could do blood tests, that would be great. I think we are all trying to do. We have also been working on that. I think there are fundamental questions that I don't think we know the answer to. So looking in the bone marrow in the cells, looking in the bone marrow in the serum of the bone marrow, or to look in the blood, which is the more reliable? We want to make sure that we have a reliable sample, of course. And how much sample do we need? Is only a few milliliters of serum, if that's what we're going to use, or plasma, is that sufficient? So I think, based on my knowledge, that I don't feel that I know which sample and how to do it is the best. I need to spend more time in the lab trying to work that out. I have better yield with flow than I have with molecular in the blood at this point, but I think if we get some more time to work it out, I hope that we will be able to have same or better sensitivity in the blood, but I'm not yet there in my lab.
Right, right. So you can see that this is a true active research project. Ken, I think that you had some thoughts?
I was just going to put this maybe into a broader context, but the whole concept of minimal residual disease is sort of looking like for one myeloma cell and maybe as 100,000 or 1 million normal cells in the bone marrow. Or as I like to say it, one New York Yankee and 100,000 or 1 million Red Sox, okay? That was in particular for Dr. Landgren, who's about to go to New York and work there. But fortunately, he missed it. But in any event, but why is this important? It's really important because we know in other diseases like leukemia, chronic myelocytic leukemia, if you get somebody, you only would look in somebody who already has a complete response by our standard test, but then go to the additional level here. We know in leukemia, chronic myelocytic leukemia, that if you are MRD negative, minimal residual disease negative by one of the fancy tests, that actually predicts for outcome. Right. And in myeloma, we actually know in allogeneic transplant, where you get transplant from a brother or sister, we talked about how that's still not done very much and it can have side effects. But if it goes well and you are MRD negative, by the assays that Ola so nicely described, we know in myeloma that predicts for a very positive outcome too. So the idea is that's just to put it in a big picture, we haven't been able to get to the level of MRD previously short of an allogeneic transplant in myeloma. Now we have new treatments, new drugs and things, and Ola's now going to lead the way along with Black Swan in terms of seeing in myeloma whether MRD, if you get to that level, one myeloma cell in 1 million normal cells or some very sensitive level, does it actually mean that you're going to do much better? That's what these kinds of tests and this Black Swan initiative will actually hopefully help
And I
us.
think the optimistic way of thinking about it is the reason why you need tests like this is because we're doing a really good job of getting people more and more into complete remission by the standard techniques. And that's really good. The problem is, despite that, still most people will eventually have their disease come back. And so if we can assess the new therapies with this sort of test and perhaps be able to differentiate people who are really, the disease is gone versus those who just still have a little bit left that we could keep chipping away, that will be a great advance.
Right, important point. Suzanne, you want to comment? Yes.
Just quick comment. I
Yes.
mean, you can see we are very excited about that initiative, MRD, but I just want to point out that you can also see, based on Ola's presentation, that this is still in development. I mean, from your centers, you sent surveys to 30 centers, only 11 do MRD. So this is still in development, and even if you are in a big center, you know, a lot of them don't kind of, you know, do not offer this. But we are really working on this, and this is our mission, to establish MRD at least in the big centers. So
Right.
just don't be disappointed if your doctor does not offer that to you.
Right,
but we are
right.
working on that, and it's important.
Right, these things are rolling out, and in fact, some of you may be aware that Ola Landgren has been at the NCI. He's actually moving to New York very soon in May, and so one thing we've been talking to him about is to make sure that he's going to continue this research and be doing MRD testing in New York, along with Suzanne, so we'll maybe have 2 centers in New York where you can get this done. I don't know if you want to comment about, you're excited about your move, I know.
Yeah, so I'm very excited. So I've been with the NIH for 10 years, and I'm very happy, and I feel that we have had a lot of support and collaboration with IMF and my other colleagues here in the room and elsewhere as well. And on May 1st, I'm moving to Memorial Sloan Kettering. We are planning on working very hard to move forward with the MRD project there.
So, yeah. So in the summer, when some of you move back to the north, you have some options now. Okay, any other questions before we head to a break? Okay.
Dr. Olaf, I enjoyed your presentation. I thought it was very interesting and very exciting moving forward. One of the things that I drew out of that was it's essential, it seems to me, for some kind of a standardization across the whole process. My question is there somebody responsible for establishing those standards and then enforcing those standards?
I think the Black Swan Research Initiative is really what we need. As I said, many institutions can do a lot of good work, but if we don't do the same work, if we don't collaborate, it's not going to change the field. So I think IMF and the Black Swan Research Initiative has taken the role moving it forward. We're also working in collaboration, for example, with the FDA. You could envision that if these tests become standardized, they could actually be used for drug approval in the future. So we are involved in discussions with the FDA. We're having a meeting in about a month where we're going to talk about this. And the FDA has expressed very strong interest in it. And they are looking for the same thing in other diseases as well. So I think the Black Swan Research Initiative is probably the strongest movement out there at this point. And I'm very excited to be part of that.
And so a key aspect of that, which I think is of considerable interest to the FDA, is that the readout from this machine, when the cells are going through and there's a printout coming from the machine, up to now, it's been related to the observer. The observer would say they calculate so many cells per million. But what we have been doing in collaboration with the group in Spain is developing a computer software program, so that the outcome from the machine is not how many colors or how many cells the person running the machine picks out. It's going to be running through a computer software program, so it will be standardized. And it will be standardized for the several different kinds of machines that potentially can be used at centers globally. And so this degree of standardization will be computerized. And so I think that this is a very attractive feature to the FDA. Okay.
We're out of time.
All right. Well, there's all day to come to breakout groups and the like. So Thank you for your attention.
Thanks,
Thank you so
Ola.
much, Ola.
You now have a short break, and if you want to start signing up for your breakouts this afternoon, the sheets are up on the bulletin boards. And remember, we just ask you to sign up so we can get an idea of how many people to assign the right room to accommodate the number of people. You can go from breakout to breakout. You don't have to stay in one breakout, but just to get an idea of